are in listen-only mode.
Good morning. Thank you for joining. This is the November 9th webinar of the Connecticut Health Policy Project on the State of Connecticut's Preventative Care Initiatives, the Health Enhancement Program, and Patient-Centered Medical Homes. I'm Ellen Andrews, Executive Director of the project, and we're very fortunate to have Kate McAvoy with us. I was just saying to Kate that I love getting bios from friends. I'm very impressed with people, but when I see their bios, then I know why. Kate started this January as the Assistant Comptroller Policy Director with the Connecticut Office of the State Comptroller. In that role, she is focusing on the office's priority areas, which include achieving improved health outcomes and cost savings in the state employee and retiree health plan and state budget transparency. For many years previously, Kate was Deputy Director of the Agency on Aging of South Central Connecticut, serving on a number of councils and boards. She's a frequent lecturer on advanced healthcare directives, conservatorship, Medicare, home and community-based services, entitlements, and healthcare policy issues. In recognition of this work, she was this year named as a Connecticut Advocacy Champion, which I heartily second, by the Center for Medicare Advocacy, and received the 2011 Carlson Award from the Connecticut Coalition on Aging. Kate served as the chair of the Executive Committee of the Elder Law section of the Connecticut Bar and periodically teaches an elder law course as an adjunct faculty member at Quinnipiac School of Law. In 2010 was elected a James Cooper Fellow of the Connecticut Bar Foundation. And that is just part of her bio. So we are very lucky to have Kate with us. A little housekeeping about the webinar. If you are listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. We'll be keeping everyone on mute until Kate is finished, and then we'll have some time for questions. To ask a question, you can raise your hand by clicking that button, or you can type your questions into the question pane text box on your screen, and you can do that at any point during the webinar. And a video of this webinar will be posted online soon. So we'll send it over to Kate.
Great. Well, good morning, everyone, and I want to thank Ellen so much for the opportunity to join you all this morning and thank her very much for her kind words. I'm humbled to be in her company in this discussion because of her leadership role, especially with respect to furthering the interests of patient-centered medical home development in Connecticut as part of the Sustainant initiative. So we have a lot of expertise coming together on this call in attendees and also under Ellen's past experience. And I hope we can illuminate some of the recent work that the state of Connecticut has undertaken. This is obviously in conjunction with and in the larger context of many diverse efforts. But again, this will give a snapshot of where we're situated. You'll see there are slides in front of you. I'm going to be addressing generally two distinct initiatives that have two common focus areas. First is addressing underutilization of preventative care. Second is, addressing some of the aspects of lack of coordination and integration of care, perhaps also remedying some access problems that people have in utilizing such services. And I do want to start from a standpoint of context setting to refer back to work that Ellen had a very significant hand in creating. That was a report that was offered by the Sustainant Board addressing matters related to patient-centered medical homes. One of the main aspects of the data on which they premised the report addressed factors that describe, incidents of utilization of preventative care in Connecticut. One of their main sources was the Commonwealth Fund, and I just wanted to start with a couple of reference points. First, Commonwealth found in 2009 in its state scorecards found that at least 12% of at-risk adults in Connecticut had not had a routine checkup in the past 2 years, as is generally indicated. Obviously, there's some differences across the age tiers. This was significantly higher for individuals living at or below the poverty level, and also for people of color, reflecting disparities of experience for those populations. Also, that report utilized some data points from the Hospital Association, and one that I thought was particularly striking was that approximately a third of emergency room visits they found were for non-urgent matters, and that 64% of those occur between 8 a.m. and 6 p.m. So that's a window that generally spans work hours. So several key aspects of data indicating there are some areas in need of remedying, that's what I'd like to talk about in that context. What is the state of Connecticut doing generally in its population, very significant population of employees and retirees, to try to address and improve upon some of those descriptors. So I'm going to advance the slides. I understand from Ellen that internet may be just a bit slow this morning, so we'll hope that they will advance periodically. You're going to be seeing in just a moment an overview of the presentation I'm going to make. I'm going to start by focusing on what's called the new Health Enhancement Program, or HEP, is the acronym that we're using, and start first by talking a bit about the historical context that led us to HEP, then some of the requirements that are articulated by the CBAC agreement. That's the agreement that was crafted between the Coalition of Unions and our governor. I'll talk about some procedural protections that have been put in place. Oh, I'm glad the slide is advanced. That's great. I'll talk about some procedural protections that we are anticipating will be of help in this program to make sure that we attend to individual rights. I'll briefly reference the cost savings assumptions that have been made in projecting out the impact of this program. And finally, I will point you to the means by which we propose to evaluate it. So again, that's HEP, or Health Enhancement Program. That title of that program has evolved a bit, so I will let you know that is its nomiker. Finally, I will address our patient-centered medical home pilot and talk again a little bit about our motivation for doing that and describe the goals and some of the metrics that we're using to advance that initiative. Great. So I'm starting with the Health Enhancement Program. Again, I wanted to expand on the kind of brief data context that I gave by giving you a little bit of background. You may be aware that until 2010, the state of Connecticut was fully insured, and for various reasons, most notably an interest in tracking and better controlling costs, in 2010 became self-insured. State of Connecticut contracts with two carriers who act as plan administrators, and those are Anthem and United. Additional information that motivated the inquiry into what became the HEP initiative, when you look historically, and this is really in recent time, looking at about 2008, 2009, 2010, looking at the experience of state employees and retirees in utilizing the health system, there were some early warning signs and some points that we wanted to address. First, and you see on the slide, there are some clusters, we're calling them, that became evident through geomapping, in which there's very high incidence of health encounters. So visits, emergency room encounters. And you see from the latter part of the slide, when our experience data for state employees and retirees is compared, and this was done by our contractor Milliman, to what we call an expected group. This is kind of a base group composed of national and regional data. We had a higher incidence of emergency room visits. So again, something that is a flag in terms of utilization of that acute care setting, perhaps for necessary reasons and perhaps for avoidable reasons. Other data points that were of interest and concern is data that reflects the use of preventative care services. That's our general term that refers to use of the annual or biannual physicals. And as you see, when we look at the trend data, we see women are modestly improving in use of physicals, but the data has remained fairly constant for men. And that's the case really for both what we call established visits. That's people who have historically gone to a PCP and are continuing to do so. And then also individuals who are newly going to see a PCP for a physical. Probably one of the most stark pieces of this information is the differences in the rate at which men and women seek physicals. And I'll just let you know for reference, for ongoing or established people, about 627 per 1,000 women who are employed by the state of Connecticut get physicals as indicated, but only 361 per 1,000 men. So there's a very big difference that involves gender in terms of seeking that preventative care. Also, when we look at kind of key screening tests that have a strong relationship to preventing the later need for acute care, we look at mammograms. We do see some improvement over time, but our utilization rate is not where we'd like it to be. You see, for women between the ages of 50 and 74, only 593 per 1,000 state employee women are receiving mammograms. And I know that report is complicated by some of the kind of national comment on mammograms, but irrespective, we'd still like to see that figure higher than it is. And then perhaps more strikingly, the data concerning colonoscopy, you see a very low incidence of state employees seeking colonoscopy in the 200 range for both women and men. So we'd like to see that improve. That's as compared to then a baseline population that also needs improvement. Let me see. Okay, if this will advance, let me see. The next slide, which has not yet advanced, just talks that it really makes reference to a point that's well known to us all, and that is that acute care is much more costly than preventative care on the whole. We have an interest from a cost-saving standpoint in reducing our acute care costs as much as we can. Let's see if this slide will go forward. And I also included in the next slide some information about that kind of amplifies on that gender differential. You'll see now the slide is advanced. The Health and Human Services Administration generally describes nationally that men are obviously much less likely than women to have visited the doctor, but more likely to be hospitalized for congestive heart failure, and also more likely to have complications of diabetes that cause hospitalization. So we have a keen interest in promoting the use of preventative care services. Obviously, that's the takeaway message there. Okay, so let me talk to you, again, the slides are advancing a bit slowly, but I'm going to keep going. The CBAC agreement is the fulcrum point of the new Health Enhancement Program. As you know, that was negotiated between the Coalition of Unions and the governor, and that is memorialized in an agreement that is posted on the CBAC website. It's also available on our website. So I'd commend to you if you want to look at the actual language, that's where you can access it. The Health Enhancement Program requires enrollment by both current state employees and employees who retire, as you see, after October 1st. People who have already retired before the effective date of the agreement may participate on a voluntary basis but are not required to. So that is just to resolve that question. There was some confusion about kind of the status of retirees. The way that this was handled is enrollees, so current state employees and individuals retiring after October 1st, are required to attest that they wish to participate. So it's an opt-in rather than an opt-out. And I think we had some obviously rationale to do it one or the other way, but the decision was to do that opt-in. So people had to say affirmatively, I wish to participate. What were the results? Obviously, we had a very contentious negotiation period, quite a lot of exposure in the media, and unfortunately some information conflating the Health Enhancement Program with some other health policy goals at the statewide level. Notwithstanding, ultimately the result really validates very strong enrollment. You see 97% of individuals who are currently employed enrolled. Only 200 specifically said that they did not wish to participate. And we had about 1,000 who took no action. There were various reasons for that. I will let you know that for the first time, State of Connecticut used an online enrollment mechanism, which is helping to move us forward in using technology and interface with it, and that seemed to work very effectively. So that's kind of another piece of this. How do we streamline access even in our administrative practices? What I'd like to briefly take you through, and I won't enumerate each and every aspect of it, but I wanted to make sure you had a source that showed what people are required to attest to do if they are participating in the Health Enhancement Program. The first element is that people are asked to get age-appropriate screenings. This is the emphasis on preventative care that we posit will have long-term yield and cost savings, and also help people have better health outcomes, obviously with intervention at an earlier point in some of the major conditions. So obviously starting at the younger end of the age spectrum, the required well child visits, and you see those are enumerated. I'll just say just a bit of comment. We are working very closely with the State of Connecticut Department of Social Services on its proposal for patient-centered medical home. They're also mirroring to a large extent some of these requirements in terms of the exams. You'll see more detail in DSS's proposal because of EPSD requirements, but there's a fair degree of consonance, and that's another piece that we're very interested in at the Office of the State Comptroller, getting common structures, getting common measures. Obviously, we believe that would be beneficial for the whole system. The next slide is adult wellness physicals, and again, that just describes the incidence of physicals that are required. Going forward, preventative screenings, obviously a key one is for cholesterol. And back to the context in which I was starting the presentation, the next slide addresses need for clinical breast exam and mammogram. You see this is a little bit differently described than some of the other requirements because it does occur per the recommendation of the provider. That reflects, as I said, there's some difference of opinion at the national level in terms of the frequency required for mammograms, but that is provider driven. So again, it does not look to supplant the provider's recommendation. It does, as you see, require a baseline screening mammogram for women who are between the ages of 35 and 39. So that is obligatory and for evidence-based reasons. Also, you see the cervical cancer screening, again, anyone 21 and older, any woman 21 and older. Then we go on to the required screenings for vision, which is a very common incidence of every 2 years. You see a parallel to commercial insurance. You also see a requirement, and there is coverage in our dental plan for 2 screenings, 2 dental cleanings per year. So each of those aspects describe, what people have to do to comply with their participation in HEP. I will just contrast this dental cleanings. Many of you are aware that in this last legislative session, the Medicaid dental coverage was actually scaled back so that individuals who are 21 and older, for whom there's no other evidence that dental disease is an aggregating factor, will only receive 1 cleaning, 1 exam, and 1 set of x-rays. So there's a little bit of a contrast here between the Medicaid benefit now and the state employee population. And again, similar to mammograms, some differences of clinical guidance at the national level in terms of what is kind of best practice, evidence-based practice for dental cleanings. Very key point that I want to emphasize is that although these are the generally required screenings that will satisfy obligation of participation in HAP, if a physician or other healthcare professional says that it's contraindicated to have any of those screenings, then his or her opinion will prevail. So again, it's inapplicable if he or she says that. some examples might be there are some upper age tiers at which the colonoscopy or the cervical cancer screening is no longer considered to be medically indicated. So that's just one example, non-exclusive, that I can provide you that might fall within that recommendation. We also will be offering additional preventative benefits. These are being developed first as a voluntary weight management initiative, and I have to tell you this is still in formation, so this may take various forms depending on which agency an individual is employed by, but obviously generally to promote weight management and awareness of BMI and some of those other factors that are preventative in nature. And then also a tobacco cessation initiative. Our RX benefit, our prescription drug benefit through the state plan currently covers pharmaceutical interventions for tobacco use, but this will expand on that perhaps with new connections for counseling. And again, that is being worked out right now. I will say that this is another area in which we are paralleling with DSS with its new I Quit initiative, the $10 million grant that DSS has received to promote tobacco cessation in the Medicaid population. So there's a nice kind of commonality of effort with that. So I talked about the preventative screenings that are a key component of compliance with HEP. A second feature, which is required for certain individuals, is if an individual has a diagnosis that falls in the 5 bullet points that you see listed on this slide, he or she is asked to participate in a counseling and education program, again, in concert with his or her primary care physician. So you see, I think it's pretty apparent why these conditions are chosen, obviously because of high incidence of acute care costs and the likelihood of improving outcomes through successful preventative measures and monitoring, and especially that aspect of coordination of care and self-management of conditions. So that is an additional requirement for people with these diagnoses. The incentives for participating in HEP, obviously this is an opt-in program, and the incentives relate to the pieces that you see listed on this slide. First, if you participate, you maintain your current premium cost share. So the obligations that you already had as an employee, whether that's for individual coverage or family coverage, remain constant. So that really yields into no increase. In this climate, obviously favorable. One of the incentives for participation in the program is that we now are trying to improve access to urgent care and walk-in clinics as a means of diverting people from inappropriately going to the emergency department, and the co-pays for those types of visits are the same as for office visits. So you're kind of leveling the field in terms of what it would cost to get that kind of immediate attention. And then you see for people who are in those 5 categories, those 5 diagnostic categories, the disease education and counseling, they will, after a successful year of participation, receive an actual cash payment, a $100 cash payment. So that's a bonus for participating. And they also have some more favorable treatment with respect to medications for the conditions that they're managing. And as you see, a reduced tier of copays for generic preferred and non-preferred drugs, also because there's so many indicators that diabetes has other co-occurring issues, and again, so many implications for acute care, no copays for medications used to treat diabetes. So an incentive to be compliant with diabetes medication. And addressing a barrier, which may be the case for some people, and that is the cost of obtaining the medications. So those are incentives for participating. The next slide talks about some modifications that we've made, some cost sharing that's intended to promote the desired outcomes. That's obviously improved health outcomes based on some common metrics we're using, lower use of the emergency room, etc. So you'll see one of the changes that has been made is that now there will be applied a small copay for emergency room visits that don't result in an admission, or where there was a reasonable alternative like an urgent care clinic. I will tell you that it's really a work in progress to establish the criteria by which this will be administered, and we will look at that. Obviously, it is going to rely on some facts in different situations, but I think that the bottom line is to try to encourage people to divert from the emergency room where it's appropriate for them to do so. There is also then, for people who did not elect to participate, and as I told you, that was only about 200 people statewide, there is a penalty associated with not participating, twofold. First, they are required to pay $100 per month additional premium cost share. And then the second aspect of cost sharing that is greater for that population is that they must also pay a $350 per person annual deductible. That is capped at $1,400 for families, irrespective of size. But again, that is the choice, is to elect to participate in the program or to pay additional cost sharing. I did want to talk briefly about medications because there are also some important changes. Initially, the CBAC agreement strictly required that anyone who is a state employee or a participating retiree receive all of his or her maintenance medications by mail order. The premise was that mail order would be cost savings, and that it might actually help to solve some of the access issues with supply. It would reduce the cost sharing for participants. As you are probably aware, there was a lot of debate about this over the summer, a lot of concern on part of local pharmacies, and a lot of comments by individuals about their desire to have an option to continue to fill those maintenance medications locally. So this actually has evolved. There are two options that people have. First, they have the opportunity to receive the initial fill of any maintenance medication at any participating pharmacy. So that's kind of their main point of contact. Then for any subsequent fill, they can either fill them via mail order through Caremark. Caremark is the state of Connecticut's pharmacy benefits manager, or they can fill at a pharmacy in Connecticut that is participating in what we're calling our maintenance drug network. Now, initially, the maintenance drug network included only the CVS stores, which is another part of the parent company that owns Caremark. But that list has significantly expanded over the past several weeks, and I'll just give you some examples. The full list of participating pharmacies is available on our website. But again, just for some examples, Stop and Shop pharmacies are participating, Big Y, ShopRite, Walmart, and Price Chopper. And we also have some independents. We have 4 of the 6 Arrow pharmacies, Apex Pharmacy in Hampden, and a pharmacy called Nathan Hale. So there's some independent participation, which we're very grateful. We have a really strong array, and every town has incidents of local sites now in which people can get the drugs. So they are not now obligated strictly and exclusively to go through mail order. So again, I hope that resolves some questions that you may have about that, because I know there was a lot of discussion about RX. Next slide talks about how compliance with the participation requirements of HAP will be determined, because there's also been some very legitimate questions about how this will occur. So you'll see the mechanism that we're proposing to use starts in about February. The first comment I'll make is that we have established a schedule of preventative screenings that individuals have to achieve. We recognize that in the first year of utilization, there may be challenges of access. We're all very well acquainted with kind of the inadequate supply of primary care practitioners in Connecticut and elsewhere, and obviously the difficulty in scheduling. Some are very, very booked in advance. And so in recognition of that, there's two things I want to say. In February, the carriers, so that's Anthem and United, will be taking a look based on their records. Office of State Comptroller will have no role in this whatsoever, and I think that's been another question. How will we be involved? It will, again, be strictly the records that are kept by the carriers in terms of utilization of services. They'll look at where people are, and people will start getting automatically generated calls to their preferred contact number, which will likely be a home number or a cell phone number. I don't know if anyone has already received any of those calls. I actually have received 2 prompting calls. So it will say something like, Kate McAvoy, we noticed that you have not, as indicated, received your mammogram. Again, just a reminder that that's indicated. We will also, through the carriers, be looking back over the past period of time in which the test is indicated. And I've given as an example, if you're required to have a physical each 3 years, we'll look back 3 years prior to October 1st and see if at any point during that period you received the test that you are required to, or the screening or the physical. This is designed to, again, give some latitude in the first year. This is, of course, going to work very easily for people who have been employed by the state during that full period of time. For people who haven't, we will allow them to present evidence that they have gotten the test or screening or visit. So there's going to be a process by which people can demonstrate compliance. So hopefully we will be as flexible as possible with that. The next question, I'm sure, is, if the carrier comes to the point of being in about June of next year, July 1st is the renewal of the plan year, and people have not fulfilled all their requirements, what will happen? So right now, what we can say is that they will be given notice, formal written notice, another contact, and we've also now got people's email, preferred email, because that was part of the enrollment process, and asked to improve their participation by getting those visits scheduled. If people do not comply by the end of the year, there is a process that's established by the feedback agreement where there will be notice to and review by what's called our Healthcare Cost Containment Committee. Healthcare Cost Containment Committee is a management employee group that is created some years ago to oversee and give support and guidance to decisions about the state healthcare plan. And the HCCC will establish grounds for appeal. We will, internal to the OSC, be writing those standards. So some examples of grounds for appeal you see there, you made a good faith effort, but you just couldn't get into your doctor because he or she was too booked up. Or you have maybe a religiously based conscientious objection. We want to try to frame those appeal grounds in a way that will be facilitative of participation. Those are not yet drafted. They're in process. As you will see in the feedback agreement, removal is solely based on failure to get those screenings and or, if applicable, to participate in the chronic disease counseling program. And if people are removed from participation, they will, effective July 1st, then be subject to that increased cost sharing. That is the additional $100 per month in premium, and then also the deductible, annual deductible. We are still determining the basis on which people can re-elect to participate. Although the feedback agreement talks about kind of a rolling process, we just have to reconcile that with federal treatment of coming on and off a health plan, because we have to offer that on a universal basis to the whole population. So that is still being reviewed. We will announce how that will occur as soon as that is resolved technically. You see in the next slide, and I really won't make much comment on this, but I just wanted you to see the proposed savings that are assumed by CBAC and the governor in their agreement. You see the various aspects of HEP there with the emergency room copay, participation and opt-outs. I will say the one comment I can make just objectively is the savings assumptions assumed a much lower rate of participation than ended up being the case. They assumed a 50% participation rate. We saw a 97% participation rate. So that's kind of a built-in difference with the assumptions. You also see some cost savings here associated with other aspects, like certain drugs coming off patent, so essentially becoming generic and saving some money there. And there's some cost savings implied there. And then you'll see a line that says other HCCC initiatives. The Healthcare Cost Containment Committee is charged with formulating other means of saving money in the health plan, and that's one of its major tasks across the scope of this year. Finally, winding up with evaluation matters, obviously this is very new initiative in Connecticut, and it's pretty new and novel for a state to be doing this. We're very, very much interested in evaluating, obviously continuing to look at trend data, to look at does this improve, which we expect it will, the incidence of preventative health screenings and dental cleanings, health outcomes associated with chronic conditions, and particularly, whether we can divert people from inappropriate acute care and rehospitalization, which is a big issue also in terms of the rate at which that currently occurs. And then the evaluation of the cost savings in diverting costs, and also in reducing our very significant prescription drug costs. So all those factors will be looked at. We are talking with a number of interested parties right now, academic institutions, some policy organizations, and probably will have diverse partners in this effort. It's going to be obviously very appealing to partner across sectors to look at that. Okay, I'm going to move on to wind up by talking about our patient-centered medical pilot. I do want to be careful to leave time for questions at the end. So I'll launch right in. The patient-centered medical home pilot, as I said at the beginning, has common goals, obviously, to increase the use of preventative care and to reduce some of those access barriers to obtaining care in the primary care milieu. This initiative began this year in last year, in July 2010. It was part of the state's December 2009 re-procurement of its health benefits, obviously going to self-insured status. And you see the two goals, coordination, and then also through payment reform mechanisms to reward providers for improving health outcomes. So to shift from that pay for service to the value-based method over time. Currently, in our patient-centered medical home pilot, we do not attribute state employees to our pilots. That's something we may consider doing in the future, but what I will say is the providers that were selected already serve a very large locus of state employees. I'll talk to you about them in just a second. So the model relies on kind of already reaching people served by that. This is in contrast to some other models like the DSS model that is proposed, and then other models nationally where there is a formal means of attribution. Our payment reform model is a hybrid. There are several different strategies, and our approach through our division director, Tom Woodruff, was really to give carriers and providers flexibility in determining what was most suitable based on their needs. So the PCMH pilot was initiated first with ProHealth physicians. This, as you I'm sure are aware, a very large practice group, approximately 225 primary care providers, 70 practices. Very excitingly, ProHealth in August achieved NCQI Level 3 certification as a patient-centered medical home, so very big practice, essentially embodying the culture and the practice, the applied practice of integration and coordination, expanded access, use of care management, and use of evidence-based guidelines. ProHealth serves about 35,000 state employees, and in total serves about 10% of the state population. So I'm sure you can see why it was attractive to go with them from a standpoint of volume and reach and impact, because they serve a very broad geographic range. This pilot was expanded in June to include Hartford Medical Group, another big practice group, and we anticipate expanding further as more groups, again, get to that NCQI level 3 or on a glide path to achieving that status. Key in the development of our PCMH pilot by Tom was to negotiate with groups and carriers to gain agreements really on two main areas. First was use of common metrics, and those include, you see at the bottom part of the slide, process measures. A key one of those is whether the practice is using EHR, which is of course required at the level 3 of the NCQI. Quality measures, those relate to the clinical guidelines, the evidence-based clinical guidelines. And then the clinical outcomes, obviously very, very key piece here is the avoidable ED visits, hospitalizations and readmissions. I put in just one example of a health outcome metric that relates to diabetes, and that's a very specific indicator of an HbA1c test at a certain identified interval. So those metrics really we've established. We are also promoting the more broad use of these metrics across other payers and providers. One example is that DSS has used many of these common metrics in its PCMH proposal, and we're negotiating with the Attorney General's office to get some approval of guidelines to expand our discussions beyond the state to private insurers to, again, promote the common use of these metrics, because obviously we have an interest in doing this on a more broad basis. The second main area of negotiations was payment reform mechanisms. Now, I will say right off the cuff, there are many different strategies that can be employed to achieve payment reform. Obviously, a key one that has been focused upon is the per member per month payment, and when you look nationally, there's a lot of emphasis on that. Also, there's, in many scenarios, upfront payments to anticipate the kind of ramping up costs of practices to expand their access, their hours, to invest in infrastructure like EHR. There's also, in different milieus, like with Medicare, calls for establishing new codes for telephone consultations, other non-face-to-face reimbursement, codes for telemedicine. So lots of different strategies, and this is really an evolving discussion. What we have done, state of Connecticut, is use three mechanisms. First is an upfront payment where it was needed to help practices, as I said, ramp up. We're fortunate ProHealth was very ahead of the curve, very affirmative in its planning process. We're also using enhanced fee-for-service compensation, and there's a lot of opinions about that, so I won't editorialize, but that's part of our mechanism. And then there are also enhanced fees and bonuses for achieving those outcomes that are described by the metrics that I referenced in the previous slide. Other carriers have also adopted some of these strategies, and that has, in one case, actually included risk sharing, so we're moving ahead. Preliminary comparative analysis, I'll leave you to read this on your own, but basically the groups, the two PCMH pilots, are already showing an effect in reducing ER visits and increasing the incidence of physician physicals, the contact with primary care physicians. So those things are absolutely great, and we're happy to see that. I will emphasize this is based on a very short time period, and we need more data and more time to go by before we can, report with confidence on these. So let me wind up by saying, again, our emphasis is on preventative care. I hope that's been kind of the main theme you've heard me talk about. The use of incentives to individuals and also to providers to focus on management of chronic conditions. And then our plans are to amplify the number of practices that we're working with, and then act as a catalyst to inspire, common use of those health outcome metrics and the peer reform modalities. We hope we can be a partner in that. And I want to thank you so much. I'm very eager to hear questions and hear your comments, and thank Ellen again for the opportunity to present.
Well, thank you very, very much, Kate. That was great. There's a lot there, and everyone should know that these slides and the video of this will be up online, because I know I'm going to have more questions for Kate as I think about all this. But if people have questions, you can put your hand up, or raise your hand, click the little button, or type one into the pane. And we have one now. Let me find how I can move this out and look at that question. Let's see, Heidi Kearns asks, let's see, how does one become involved in the chronic disease program? Will this be online, and can I get a, oh, the PowerPoint will be online and she can get a copy. This info is great, and she's thanking very much for it.
Oh, that's terrific. That's a very good question. Thank you. The chronic disease management, basically if someone has a diagnosis that falls in any of those 5 indicated groups, his or her practitioner will talk to him or her about the education. There will be guidelines established by the carriers. So someone does not have to, go and enroll in a program. It's really between him or her and his or her physician.
Okay. Well, I had a question that's come up. It's been reported in the press as well. We have a really good problem, which is that 97% of people signed up for this. But which is a good problem to have. But a concern is how realistic are the savings given that?
Yeah, that's a really excellent question. What I will say is Kevin, our comptroller, Kevin Lembo, was just quoted in a great article in the Connecticut Law Tribune. Some of you may have seen. And, his comment on that is, first of all, we think it's terrific. There was such a high uptake. We're very gratified by that. Certainly the cost savings we have to monitor, because there were cost savings associated with a lower rate of utilization. So we already know there's a differential between that savings. We also really want to track, and we will be, you'll see this addressed in his communications in the near future. We want to track, what is the impact of increased primary care utilization. We would expect that there would be a spike in use of those types of visits because they're required. What we are positing is that although there may be increased costs associated in the short run, obviously the goal is to forestall acute care costs in the future. So that long-range savings is the investment that we're making now. But I will say his public position on that's really well captured in the Law Tribune article if you have a chance to read that.
Okay. Kathleen Missett asks, can you clarify the payment schedule for periodontal care? In the past, the plan paid 50% up to a $500 annual maximum. I was told that the 50% payment still applies, but there is no longer an annual maximum. Is that correct? And if so, when does it or did it go into effect?
I do have to apologize. That's outside my knowledge. What I would say is that there is what's called the State of Connecticut Employee Healthcare Options Planner that is posted on our website. And if that question is not resolved fully by that document, our Health Policy Division that's headed by Tom Woodruff could answer that question for you directly. And let me just give that phone number is 860-702-3481. So 702-3481. That question is specific, but it points to, what do people do if they have specific questions of coverage. They can, definitely go directly to our Health Policy Division and just pose those types of questions, because some of these things obviously are new, and we want to make sure with dental, also with prescription drug coverage, that people have the information they need and there's no access barriers.
Okay, I'm going to ask another question. Just take the prerogative of the moderator. I was fascinated by the information, the data analysis you got from Milliman that showed the geo-mapping with high utilization, say, of ER use, and also the gender difference in physicals. What are you doing specifically to target those, like find those areas and find out why people are going to the ER and address that? Is it, provider specific, or is it patient specific? And also, what are you doing to get men to get physicals?
Yeah, so excellent question. So we are doing some meta-analysis with the clusters. Obviously, we have a lot of data because we're self-insured, so we can really look at that. We can look at it in terms of where it occurs geographically. We can look at it as correlated with occupation, because there are some clusters that we posit have something to do with the type of work people are involved in. So there's a lot of analysis going on. That is through Milliman, and we should be able to talk more informedly about that, in the near future as we see experience with that. The second question is very dear to my heart, and what we're talking about internally, we've tried to review a lot of the literature about what does inspire men to go to the doctor. There's a very large-scale survey that was conducted by Rutgers, which talks about what they call a masculinity belief, that men really prefer not to see themselves as susceptible from a medical standpoint, that they posit that is the main barrier, that masculinity belief that inhibits men from going. So we're looking at campaigns, like there was a campaign through HHS and Tom Joyner that was called Take a Loved One to Work to the Doctor. I always say to work because I conflate it with Take Your Children to Work. But it's Take a Loved One to the Doctor Day, looking at the practical reality that men often don't want to go, and to look at, is there a spouse, is there an adult child, is there a friend or caregiver to help kind of inspire them to do that. And I don't know if you all remember seeing AARP had a similar campaign where they actually had caregivers kind of saying, you should do this for me. It's not just your own interest. We're also looking at some aspects of how we can work on a peer basis, potentially use prominent men as kind of stakeholders, and to work on pathways that have to do with that, especially for people of color, and to do this in a way that addresses disparities, because those incidences of use of primary care are even more stark and of concern, especially for African American and Hispanic individuals. So that is going to be a big area of focus for us this year, and it's something that, when you look at data, that was probably one of the most compelling pieces that came out.
That's fascinating. Well, we have one more. We're getting close to the end, and we have one more question from Heidi that actually is a perfect final question. She asked for the website address where the PowerPoint can be found. It's on our website, www.cthealthpolicy.org. And if you go over to the left-hand side, the purple column, and click on webinars, you can find the slides from all of our webinars. But she also asks, she has more questions about the chronic disease program, and she's asking Kate who she can call about that. Is that same number that you gave before?
Absolutely. So again, that's our health policy division. And I do have to say, Heidi, that that really is, as I said, the carriers are responsible for establishing those guidelines. So it may be possible to give you some additional detail, but as that rolls out more over time. And some of this is just, it does require some amplification from the agreement, because what we had to work with was an agreement that kind of generally said what we were to do, and we're kind of playing that out.
Well, great. This has been incredibly helpful. Thank you, Kate.
Thank you so much.
Thanks. And anyone, again, who wants to see the slides or hear the video can go to our website. Thanks.
Thank you.